Good morning.
Excuse me, could we ask that those who are talking step outside? Thank you very much, everybody.
Good morning. Dr. Allison Triconde, coming from Pelvic Rehabilitation Medicine in New York City. And we are a physiatry-based practice, and we treat male-female pelvic pain. Our study is based on an approach to the urological chronic pelvic pain syndrome. No disclosures. Essentially, with prostatitis, it's challenging to both diagnose and treat, and the nomenclature has changed by the NIH in the past year. It used to be called chronic prostatitis or chronic pelvic pain syndrome, combining with interstitial cystitis and painful bladder syndrome, now calling urological chronic pelvic pain syndrome. And again, poorly understood condition, difficult to diagnose, and the treatment at this point can be challenging. So this is the anatomy that, as physiatrists, we are working with. Essentially, we're treating the two major nerves in the pelvis, the pudendal nerve and its branches, as well as the posterior femoral cutaneous nerve, in combination with the levator ani muscles. The treatment approach that we do, essentially for patients who fail conservative therapy, which is always at least 3 months of pelvic floor physical therapy, is we do a series of nerve hydrodissection under ultrasound guidance externally, treating both the pudendal nerve and its branches with the posterior femoral cutaneous nerve, in combination with trigger point injections to the muscles of the levator ani. The goal of our program really is to treat the neurogenic inflammation, to reset the peripheral nerves, as well as to decrease the acidity of the environment. In addition, we're looking to improve the muscle elasticity, lengthen, strengthen muscles, increase blood flow, and improve the function for pelvic floor. We had 8 males in our study, age range 24 to 61, mean age of 31.8 years. They were all diagnosed with urological chronic pelvic pain syndrome. Average duration was 21 months for their symptoms. The data collection that we used was the VAS scale, as well as the functional pelvic pain scale. We did the pre-treatment and then 3 months post-protocol. For functional pelvic pain, we're assessing bladder, bowel, intercourse, their exercise, so walking, running, and lifting. For working, really it was more their ability to sit with pelvic pain that is quite often an issue, as well as their ability to sleep. So for the results, for the VAS score, pre and post-treatment, it improved from 3.3 to 1.8. And for the functional pelvic pain score, went from 11 down to 6.3 post-treatment. In conclusion, urological chronic pelvic pain syndrome is difficult to treat and difficult to diagnose, and the benefits of the study show that this is a promising protocol. We do need larger studies with a larger N to really take a deeper look at it. Thank you.
Thank you very much. Is there any question from the floor? Yes, please, go ahead.
Said from United Kingdom. So what exactly did you inject and where did you inject?
So the standard protocol would be a combination of 1% lidocaine and an anti-inflammatory agent. What we use is dexamethasone for the first time on each side, so we just treat one side at a time. Then we transition away from dexamethasone to something called Trameal. Injectable, it's similar to arnica. It's a homeopathic medicine, really inhibiting TNF-alpha and interleukin-6. So we combine that with the lidocaine as well.
Dr. Payne?
Thank you. Chris Payne from California. It's refreshing to have non-urologists, gynecologists help us out with this.
Thank you.
I'd like to emphasize, though, when you say you use CPPS, that the S is a syndrome. This is a very heterogeneous group of people. They don't have a disease. You see, PPS is not going to be a disease. So I'm wondering, do you have exam findings like abnormal pudendal nerve findings, abnormal musculoskeletal findings that lead you to specifically apply this approach? And the people that have certain findings maybe did better than that average. You know, maybe you can start to identify people that really do respond to this approach.
Right. So the people who we see respond best are really patients essentially who have either allodynia or hyperpathia diffusely within the pudendal nerve and its distribution, so the inferior rectal branch as well as the perineal. Those are the people that really respond well, in addition to not only muscle spasm, but a lot of times they'll have the twitch response on exam and tenderness to palpation as well. So the more challenging patients actually are when there is a pudendal neuropathy in a smaller area, either real nerve compression or essentially the function of the nerve has been compromised. So those are the more challenging patients. So to your point, yes, when there's diffuse tenderness, diffuse hyperpathia, and or allodynia, they do well. When it's in a small distribution, it's very challenging.
Thank you very much.
Yep.
My name's Neil Galloway. I'll be co-chairing this session. I'd encourage our speakers to try to keep their talks as close as they can to 3 minutes to leave plenty of time for discussion. Our next presentation is from Angie Rantel.